We have Sharan Ram talking today on early life antibiotic use and the risk of childhood type 1 diabetes in a nationwide cohort study using data linkage. Sharan is a public health researcher based at the Center of Public Health Research at Massey University. Previously served as a maternal and child health program officer at UNICEF Multi-Country Office in Suva, Fiji, and is an operational researcher slash research coordinator at Fiji National University, or at the time, the Fiji School of Medicine. Sharan has also been very helpful in our activities as the VHIN, most recently really being in support in our new practical skills in IDI research course that was run in November and February in the Data Lab at Stats New Zealand.
Thank you, Martin, for the lovely introduction. Yes, my name is Sharan, and today my presentation is on antibiotics in early life and risk of childhood type 1 diabetes. And as you can see on the screen, it says it is a data linkage retrospective cohort study. So this was part of my PhD study, and it is one of those studies that I am presenting. And here is the standard disclaimer that I would like to share, and to show that these are not official statistics and they are from de-identified data that we've got from the IDI, which is part of the Statistics New Zealand, and the interpretations are mine. So I will be taking you through the introduction, and in the introduction, I'll talk about a bit of background on type 1 diabetes, and also provide you an epidemiology of type 1 diabetes, as well as why we are focusing here on antibiotics. Then I will run you through the methods and, of course, the results, and then we'll finish with some strength and conclusions. And we'll provide you some time to ask some questions as well. So in the introduction, like, the type 1 diabetes is a complex autoimmune condition whereby the pancreatic beta cell is unable to produce insulin, and it is because the pancreatic beta cells are destroyed, and because of the lack of insulin, the blood glucose level is not managed. Some of the signs and symptoms of type 1 diabetes are excessive thirst, weight loss, frequent urination, fast heart rate, excessive hunger, fatigue, and blurred vision. Type 1 diabetes is managed by regular monitoring of the blood glucose levels, and it requires lifelong insulin injection. And those with type 1 diabetes have to follow a healthy diet and exercise regularly. In terms of the epidemiology, globally, the incidence of type 1 diabetes varies by region. On average, we have about 15 to 20 cases per 100,000 annually, and it is highest in the Northern Europe and North America, so-called the developed nations, versus lower incidence in Asia and Africa, which is pretty low compared to the global average, which is 5 per 100,000 annually. Type 1 diabetes is projected to double in the next 30 years. And unfortunately, New Zealand has higher than the global average, which is 20 to 25 cases per 100,000 annually. Now, type 1 diabetes can have both genetic and environmental contributors. The genetic change has fairly remained consistent over the years, but there has been a lot of changes in the environment over the last few decades, which have raised concerns, including diet, pollution, and antibiotic use. Antibiotics stand out for several reasons, because antibiotics have the ability to influence the gut microbiome, and the process is known as dysbiosis, and that can influence the immune development. Also, antibiotic has also greatly increased in the last few decades, and it is reflected by the global antibiotic sales data. And also, several studies have now shown that the prescriptions is pretty high for antibiotic use. So why we're talking about the antibiotic, as I mentioned, is that it can influence the gut microbiome. And what is the human gut microbiome? So when we talk about the gut microbiome, we are talking about the community of bacteria that lives in our gut. And in early life, the gut microbiome is critical for maturation of the immune system. And it is hypothesized that antibiotic use impacts that particular gut microbiota, which we've just mentioned, is dysbiosis, and it can have a impact on the immune system and can cause autoimmune diseases like type 1 diabetes. Diet and pollution can also influence the gut, but antibiotics are more known to acutely disrupt the microbiome, particularly during infancy, pregnancy and infancy. So the aim of our investigation was to find out whether antibiotic use in early life can increase the risk of development of type 1 diabetes. And in terms of the study design, we used a retrospective cohort study using the data from Statistics New Zealand, which is the IDI. And of course, it was a data linkage study linking the different tables. So what we did was we selected a birth cohort that was born between October 2005 to December 2010. And after removing children who had left New Zealand, migrated, or died before the age of 5, we had a cohort size of 315,758 children. And we followed them for until the end of 2021. So in terms of the exposure and the outcome, here our exposure was antibiotic use. And we used the data sources that we used was pharmaceutical data for the antibiotic prescription. And our outcome was type 1 diabetes. And we used several data sources for this one. That was pharmaceutical data again. That was for insulin prescription, because those with type 1 diabetes will be prescribed insulin. And then we also use laboratory claims data, hospitalization data, and outpatient data. Our confounders were sex, ethnicity, deprivation index, urban-rural residence, maternal age at birth, birth weight, and mode of delivery. So in terms of data analysis, we have had two parts. The first part, because we were looking at the antibiotic exposure, we delved a bit more into the patterns of antibiotic use, which I will also be presenting today, and not only the findings for antibiotic use and risk of type 1 diabetes. So the first part of the data analysis was on patterns of antibiotic use, and I will be presenting on some descriptive data, as well as we used negative binomial regression, in which we present results for the incident rate ratios of antibiotic use. Part 2 of the analysis was focused on the antibiotic use and risk of type 1 diabetes, and we used Cox regression model to determine the hazard risk for type 1 diabetes. Now, getting onto the results. So part 1 of the results section is on patterns of antibiotic use. So first, I'm going to discuss on the antibiotic use during pregnancy. So you can see that among the pregnant women, 30% of women were prescribed more than or at least one antibiotic course, and the main antibiotic that was prescribed was penicillin, which was 73.7%, and it was primarily amoxicillin. We saw that there were subgroup differences in antibiotic use. So the first one is on ethnicity, and we had higher antibiotic use among the Pacific mothers, which was 37% higher rates of prescription compared to the New Zealand Europeans. Among the Maori, we had 30% higher, and then Mela, which is Middle Eastern, Latin American, and African populations of mothers, we had 16% higher rates of prescription compared to the New Zealand Europeans. We also had differences in the deprivation index, and you can see that we had a higher use in the most deprived deciles, which is over 50% higher compared to the least deprived. Birth weight, we had those mothers with had children with lower birth weight babies had 15% higher rate of prescription. And we also noticed in terms of mode of deliveries, those who had deliveries by cesarean section and emergency, they had higher rates of prescription compared to those with normal or vaginal delivery. Now, the antibiotic use among or during the first 5 years of life. In the first 5 years of life, we had 96% of the children prescribed at least one antibiotics. And again, the most common antibiotic that was prescribed was penicillin and primarily amoxicillin, which was over 30%. Also, we had subgroup differences here. You can see we had a higher prescription for males, which is 9% higher compared to the females. But during the prenatal or the pregnancy phase, there was no differences in mothers who had a male or female child. They didn't have any differences in the prescription. Now, in terms of ethnicity, again, we can see similar patterns. We had higher use in Pacifica, which is 32% higher prescription rate. Also in Maori and Middle East and or Mela group compared to the New Zealand Europeans. Asians actually had lower compared to the New Zealand Europeans. Again, for the deprivation index, we can see that the most deprived group had 21% higher prescription compared to the least deprived, which is the reference group. And we had those children who were born, those with low birth weight, as well as those who were delivered by cesarean section had higher antibiotic use. Finally, we also noticed seasonal variation in antibiotic prescription with higher antibiotic use in winter months. Now, going on to the other part of the study, which is actually, I would say, the main part, which is antibiotic use and the risk of diabetes. So first, I'm going to talk about antibiotic use during pregnancy and the risk of type 1 diabetes. As I have mentioned that we had 30% of pregnant women who had received at least one antibiotic course. Now, the number of children who were diagnosed with type 1 diabetes were 1,000 or 1,132 cases, and we counted those cases from birth until the end of the study. So in terms of the finding, we saw that each additional prescription increased the type 1 diabetes risk by 5%. And you can see that we have pretty narrow confidence interval, and it is a significant finding. And we did several different types of analysis. The first one, we used antibiotic as a continuous variable. We also did what we call a dose-response relationship, and we found that there was a dose-response relationship. We had several categories. In case of during pregnancy, we had the reference group which was 0. Then we had 1, 2, and then greater than 3 courses. And we found that those who were prescribed or mothers who were prescribed more than 3 courses of antibiotics were 86% higher risk or were at a 86% higher risk of developing, or their children rather, at a 86% higher risk of developing type 1 diabetes. In terms of antibiotics classes, we had 5 classes of antibiotics. We found significant association with penicillin and cephalosporins. The other categories which we did not actually see association was macrolides, tetracyclines, and a group which we called other antibiotics. Also, we saw an association with both moderate and broad spectrum antibiotics, and you can see that with moderate we had 57% higher risk of developing type 1 diabetes, and with broad spectrum it was 30%. Now, going to antibiotic use in the first 5 years of life and risk of type 1 diabetes. As I've mentioned before, we had 96% of children who were exposed to antibiotics, and the number of cases that we found which had type 1 diabetes is 906 cases, and we counted these cases from 5th birthday onwards. And here we saw that each additional prescription increased the risk by 2%. We can say that it is pretty low, but then the confidence interval again is pretty narrow and it is significant. Again, we saw a dose-response relationship. Now here we had a number of categories, and you can see that because during the first 5 years of life, there's quite a large number of antibiotics that the children were prescribed. So we saw that greater than 13 or greater than equal to 13 courses of antibiotics, the risk of type 1 diabetes increased 93%. For this one, in terms of antibiotic classes, all the classes showed significant association except for tetracyclines. And I think one of the reasons is because tetracyclines was least prescribed antibiotic, and we didn't have the power for that to find any association. Again, we had broad spectrum antibiotic, which showed the highest risk of type 1 diabetes, which is 74% increased risk. Now, in terms of the strength and limitations, in the strength of this study was that we had a large population size because we used the IDI data. So basically, we used the national population or the national cohort, which were born between that particular period of time. And then also we used linked data, which recalled a bias of antibiotic use because we did not have to ask mothers, but just depend on the data that was available in the idea. So it reduces the recall bias. And we used 3 different algorithms to identify type 1 diabetes cases. So we are certain that we have identified all type 1 diabetes cases. In terms of limitations, we cannot draw conclusion on causality because this was an observational study. And also there's possibility of reverse causation where early symptoms of the disease or type 1 diabetes could be the reason for prescription. And also confounding by indication because we did not have the data on indications for which the antibiotic was prescribed. Further, we don't have hospital antibiotic dispensation captured within the IDI, so we could be underestimating the antibiotic that is used by the children. However, on the other hand, we are also assuming that all the antibiotic that is dispensed or prescribed is also consumed. We don't really know how much or the duration of the antibiotic use from the prescription data. So in terms of the conclusion, we can say that we're not trying to demonize antibiotic use because you know that antibiotic is very critical and it is prescribed when it is when children need it for infections. So we can say that antibiotic use during pregnancy and in the first 5 years is associated with increased risk of developing type 1 diabetes, and the risk is amplified with increased dosage. That means there's a dose-response relationship. So in terms of next step, what I'm doing now is again looking at the same cohort of children and looking at other autoimmune conditions such as ADHD and IBD, and we're looking at the association between antibiotic use both in pregnancy and in the postnatal period to see if there's an association with ADHD and IBD. How did you distinguish type 1 from type 2 diabetes in farms, labs, and outpatient? So basically, they have different ICD codes when we are looking at the hospitalization data. So that was one of the way in which we were able to distinguish between type 1 and type 2 diabetes. Do you think the association is related more to antibiotics or the underlying infection being treated? Yes, so that is a very important question. So we don't really know that because we do not have the data on indications for which the antibiotics were prescribed. And I think this is common for these kind of studies where we are looking at antibiotic use with other conditions. So unfortunately, we don't have the data on this one. So we really cannot say whether there's an association with antibiotic use or the underlying infection. And that is what I meant when I said we had indication bias.
I guess like antibiotic use in the family is highly correlated because yeah, there are like lots of infections maybe going around in the family. And you presented that separate regressions for antibiotic use in pregnancy and in early childhood. Have you tried like putting it together and see what is actually, if you kind of do it in one regression, like what is actually the driver uh, of your correlation between antibiotic use and diabetes? Do you know what I mean?
Thomas, that's an interesting question because that is one of the things we thought about it probably kind of later on once I had kind of done most of the analysis. And do you actually mean whether we are looking at combined impact of the antibiotic use? And that is one of the things that I am actually doing right now. So we're looking at the antibiotic use by the mother and by the child, and then looking at the risk, whether the combined, because we can have maybe the antibiotic use not by the mother and by the child only, or by the mother and not by the child, or also the combined effect of, or the combined impact of the antibiotic consumption both by the mother as well as the child to see if that results in increased risk. Yeah. No, we
Thank you.
haven't looked at that. So that
Yeah,
is one of
that
the
would be
things that I'm
interesting. Yeah.
looking at now. Thank you.
Yeah. Cool. Thanks.
I just wondered if you had any thoughts on like next steps being to estimate the causal impact.
Well, at the moment, I'm not certain about that, but we have had some indications that the data on the indications or primary care will be loaded on the IDI, and we might be able to do that in future. But as it is, we may not be able to do that. Yeah. Thank you.
Thank you.
And also, as I've mentioned, that we are going to look at the other association of antibiotic use. So if anybody in the audience has already looked at ADHD and IBD, it would be good to hear from you. Thank you.
I wonder if you could use like in terms of getting to a causal analysis, if you could use like the variation in timing of birth, because antibiotic use varies so much between winter and summer, and if that would be kind of worthwhile to explore, compare, yeah, people who get born at different times of the year, because they're
Yeah,
like more and less likely to receive to get antibiotics during pregnancy.
Thank you for that. Yeah.
Thanks, Sharan, for presenting today, and thanks to all for attending and for the questions.